Hi, my name is with NF1, often have multiple neurofibromas. These patients should be offered resection for symptomatic tumors. Risk of malignant degeneration is up to 10%. Malignant neurofibromas have the histologic characteristics of sarcoma, malignant nerve sheath tumors. Malignant nerve sheath tumors include solitary sarcomas, degenerated neurofibromas, and neuroepitheliomas. Patients with malignant peripheral nerve tumors typically complain of constant pain, rather than pain only on palpation, and are more likely to have motor and sensory deficits in the distribution of the parent nerve. Treatment for these tumors is radical excision. This often requires sacrifice of the parent nerve. Invasion of nearby soft tissues may occur, and entrapment neuropathies. Entrapment neuropathy presents as neurologic dysfunction in nerves passing through a pathologically small, fixed space. Nerve dysfunction may result directly from chronic, repetitive pressure on the nerve. Entrapment. The tumor. Usually EMG NCS demonstrates slowing across the entrapped segment of nerve. Mechanical peripheral nerve disorders resulting from trauma, brachial plexus disruption, radial nerve damage from humerus fractures, and common peroneal nerve crush injuries are discussed in the section Trauma. Ulnar neuropathy. The ulnar nerve has contributions from the C7, C8, and T1 nerve roots, arises from the medial core of the brachial plexus, and supplies most of the intrinsic hand muscles, interossi, and third and fourth lumbricals, and sensation to the fourth and fifth digits. It passes posteriorly to the medial epicondyle at the elbow in the condylar groove. This segment is superficial and subject to external compression and repetitive minor impacts. Patients with ulnar entrapment at the elbow present, with numbness and tingling in the medial palm, as well as the fourth and fifth digits. Motor deficits include weakness and wasting of the intrinsic hand muscles. Treatment for symptomatic ulnar entrapment neuropathy is surgical exploration and incision of the fibrous aponeurotic arch that overlies the nerve. A 6 cm curvilinear incision centered between the medial epicondyle and the olecranon allows exploration of up to 10 centimeters of nerve and lysis of compressive tissues. Carpal tunnel syndrome. The median nerve has contributions from the C5 to T1 nerve roots, arises from the medial and lateral cords of the brachial plexus, and supplies the muscles of wrist and finger flexion and sensation to the palmar aspect of the first, second, and third digits. The median nerve passes through the carpal tunnel in the wrist, lying superficial to the 4 deep and 4 superficial flexor tendons. The transverse carpal ligament is a tough fibrous band that forms the roof of the carpal tunnel. The ligament attaches to the pisiform and hamate medially, and the trapezium and scaphoid laterally. Patients complain of numbness and tingling in the supplied digits, clumsiness, and worsening with sleep or repetitive wrist movement. Patients may notice wasting of the thenar eminence. Treatment for symptomatic carpal tunnel syndrome, unresponsive to splinting, analgesics, and rest is surgical division of the flexor retinaculum. This often provides prompt relief of pain symptoms and slow recovery of numbness and strength. Autoimmune and inflammatory disorders. These are not surgical diseases, but they merit brief mention, as they are included in the differential diagnosis for new onset weakness. Their characteristic presentations help distinguish them from weakness due to structural lesions. Guillain-Barré syndrome. Guillain-Barré syndrome is an acute inflammatory, demyelinating polyradiculopathy, often occurring after viral infection, surgery, inoculations, or mycoplasma infections. Patients classically present with weakness ascending from the legs to the body, arms, and even cranial nerves. Symptoms usually progress over 2 to 4 weeks and then resolve. Care is supportive. Respiratory weakness may require ventilatory support. Myasthenia gravis. Myasthenia gravis is an autoimmune process in which antibodies form to the acetylcholine receptors of muscles, leading to fluctuating weakness. Most patients have either thymic hyperplasia or thymoma. The most common symptoms are diplopia, ptosis, dysarthria, and dysphagia. More severe cases have limb or respiratory involvement. Weakness worsens with repetitive movement. Treatment is with acetylcholinesterase inhibitors and possible thymectomy. Eaton-Lambert syndrome. Eaton-Lambert syndrome is an autoimmune process with antibodies to the presynaptic calcium channels. This is a paraneoplastic syndrome most commonly associated with oat cell carcinoma. Patients have weakness of proximal limb muscles that improves with repetitive movement. This diagnosis must prompt oncologic evaluation. Infection. CNS infections of interest to neurosurgeons include those that cause focal neurologic deficit due to mass effect, requires surgery. 7 is insufficient, cause mechanical instability of the spine, or occur after neurosurgical procedures. Cranial osteomyelitis. The skull is highly vascular and resistant to infections. Osteomyelitis of the skull may develop by contiguous spread from pyogenic sinus disease or from contamination by penetrating trauma. Staphylococcus aureus and S. epidermidis are the most frequent causative organisms. Patients usually present with redness, swelling, and pain. Contrast head CT aids. Diagnosis and shows the extent of involved bone, along with associated abscesses or empyema. Osteomyelitis treatment entails surgical debridement of involved bone, followed by 2 to 4 months of antibiotics. Craniotomy wound infections are a special concern because performing a craniotomy creates a devascularized free bone flap susceptible to infection and not penetrated by antibiotics. These wounds must be debrided and the bone flaps removed and discarded. Subsequent care involves appropriate antibiotic therapy, observation for signs of recurrent infection off antibiotics, and return to the organ for titanium or methyl methacrylate cranioplasty 6 to 12 months later. Subdural empyema. Subdural empyema is a rapidly progressive pyogenic infection. The subdural space lacks significant barriers to the spread of the infection, such as compartmentalization or septations. Subdural empyemas usually occur over the cerebral convexities. Potential infectious sources include sinus disease, penetrating trauma, and otitis. Streptococci and staphylococci are the most frequent sources. Presenting symptoms include fever, headache, neck stiffness, seizures, or focal neurologic deficit. Neurologic deficit results from inflammation of cortical blood vessels, leading to thrombosis and stroke. The most common deficit is contralateral hemiparesis. Patients with suggestive symptoms should undergo rapid contrast CT scan. LP frequently fails to yield the offending organism and risks herniation due to mass effect. Typical treatment is wide hemicraniectomy, dural opening, and lavage. The pus may be thick or septated, making burr hole drainage or small craniotomy insufficient. Patients then require 1 to 2 months of antibiotics. Subdural empyema has 10% to 20% mortality risk and common chronic sequelae, including development of a seizure disorder and residual hemiparesis. However, many patients do make a good recovery. Brain abscess. Brain abscess is encapsulated infection within the brain parenchyma. It may spread hematogenously in patients with endocarditis or intracardiac or intrapulmonary right to left shunts, by migration from the sinuses or ear, or via direct seeding by penetrating trauma. Disorganized cerebritis often precedes formation of the organized walled-off abscess. Patients may present with nonspecific symptoms such as headache, nausea, or lethargy, or with focal neurologic deficits such as hemiparesis. Alternatively, patients may present in extremis if the abscess ruptures into the ventricular system. Abscesses appear as well demarcated, ring-enhancing, thin-walled lesions on CT scan and MR. Pyogenic vertebral osteomyelitis. Pyogenic vertebral osteomyelitis is a destructive bacterial infection of the vertebrae, usually of the vertebral body. Vertebral osteomyelitis frequently results from hematogenic spread of distant disease, but may occur as an extension of adjacent disease, such as psoas abscess or perinephric abscess. S. aureus and Enterobacter spp are the most frequent etiologic organisms. Patients usually present with fever and back pain. Diabetics, IV drug abusers, and dialysis patients have increased incidence of vertebral osteomyelitis. Epidural extension may lead to compression of the spinal cord or nerve roots with resultant neurologic deficit. Osteomyelitis presents a lytic picture on imaging and must be distinguished from neoplastic disease. Adjacent intervertebral disc involvement occurs frequently with pyogenic osteomyelitis, but rarely with neoplasia. Plain films and CT help assess the extent of bony destruction or deformity such as kyphosis. MRI shows adjacent soft tissue or epidural disease. Most cases can be treated successfully with antibiotics alone, although the organism must be isolated to steer Discitis. Primary infection of the intervertebral disc space, or discitis, is most commonly secondary to postoperative infections. Spontaneous discitis occurs more commonly in children. S. aureus and S. epidermidis account for most cases. The primary symptom is back pain. Other signs: epidural abscess. Epidural abscesses may arise from or spread to the adjacent bone or disc, so distinguishing between vertebral osteomyelitis or discitis and a spinal epidural abscess may be difficult. The most common presenting signs and symptoms are back pain, fever, and tenderness to palpation of the spine. The most significant risk of epidural abscess is weakness, progressing to paralysis due to spinal cord or nerve root damage. Cord and root damage may be due to direct compression or to inflammatory thrombosis, resulting in venous infarction. S. aureus and Streptococcus spp are the most common organisms. Methicillin-resistant S. aureus now constitutes a significant proportion of these infections, as high as 40%. The source may be hematogenous spread, local extension, or operative contamination. MRI best demonstrates the epidural space and degree of neurocompromise. Patients with spinal epidural abscess and neurologic compromise should undergo surgical debridement for decompression and diagnosis, followed by culture-directed antibiotic therapy. Relatively, epilepsy surgery. Seizures result from uncontrolled neuronal electrical activity. Seizures may result from irritative lesions in the brain, such as tumors or hematomas, or from physiologic or structural abnormalities. Seizures may involve a part of the brain focal, or the entire brain generalized. Focal seizures may be associated with normal consciousness simple, or decreased consciousness complex. All generalized seizures cause loss of consciousness. Focal seizures may secondarily generalize. Patients with multiple unprovoked seizures over time are considered to have epilepsy. The type of epilepsy depends on such factors as type of seizures, electroencephalographic EEG findings, associated syndromes, and identifiable etiologies. All patients with unexplained seizures, i.e. no obvious cause such as head trauma or alcohol withdrawal, require thorough neurologic evaluation, including imaging to evaluate for a mass lesion. Anti-epileptic drugs, AEDs, form the first line of therapy for epilepsy. Initially as monotherapy, then as combination therapy. Epilepsy patients who have failed satisfactory trials of several AED combination regimens may be candidates for surgical intervention. Lack of seizure control or patient intolerance of the medications may constitute failure. Epilepsy surgery can decrease the frequency of seizures by resection of the electrical source of the seizures, or decrease the severity of seizures by disconnecting white matter tracts through which the abnormal electrical activity spreads. 4 types of epilepsy surgery are discussed in sections that follow. Epilepsy surgery appears to be extremely underused, given the relatively low risk of the procedures, and the crippling social and economic effects of uncontrolled or partially controlled epilepsy. Patients with symptoms, imaging abnormalities, and EEG analysis compatible with a specific seizure focus are most likely to have good results from epilepsy surgery. Anterior temporal lobectomy. Medial temporal lobe structural abnormalities can lead to complex partial seizures, CPS. Many patients with CPS have poor seizure control on medications. Patients with CPS may have significant reduction in seizure frequency or cessation of seizures after resection of the anterior temporal lobe. The amygdala and the head of the hippocampus are removed as part of the lobectomy. Resection may be taken back approximately 4.5 centimeters from the temporal tip in the language-dominant hemisphere and 6 centimeters from the temporal tip in the language-non-dominant hemisphere, with low risk of significant neurologic deficits. The 2 main risks of anterior temporal lobectomy are memory impairment and visual loss. Removal of the hippocampus in a patient with an atrophied or non-functional contralateral hippocampus causes a global memory deficit. Interruption of the optic radiations which carry visual signals from the contralateral superior visual quadrants of both eyes causes a contralateral superior quadrantanopia known as a pie-in-the-sky field cut. Corpus callosotomy. Patients with generalized seizures, atonic seizures associated with drop attacks or absent seizures, who are found to have bilaterally coordinated pathologic cortical discharges on electroencephalogram and who fail AED therapy may be candidates for corpus callosotomy. The corpus callosum is a large white matter tract that connects the cerebral hemispheres. Loss of consciousness requires simultaneous seizure activity in both hemispheres. Focal or partial seizures may spread via the corpus callosum to the contralateral hemisphere, causing generalization and loss of consciousness. Division of the corpus callosum can interrupt this spread. Patients may have decreased numbers of seizures and/or fewer episodes of lost consciousness. Usually only the anterior half or 2/3 of the corpus callosum is divided. As more extensive division increases the risk of disconnection syndrome. Patients with disconnection syndrome are unable to match objects in the opposite visual hemifields, to identify objects held in one hand with the other hemifield, and to write with the left hand or name objects held in the left hand in left hemisphere dominant patients. Hemispherectomy. Children with intractable epilepsy, structural anomalies in one hemisphere, and contralateral hemiplegia may have improved seizure control after resection of the hemisphere, anatomic hemispherectomy, or disruption of all connections to the hemisphere, functional hemispherectomy. Functional hemispherectomy often is preferred over anatomic hemispherectomy because of the high incidence of complications such as hematoma formation and ventriculoperitoneal shunt dependence associated with the latter. Vagus nerve stimulation. Neuromodulatory treatments like vagus nerve stimulation, VNS, approved by the U.S. Food and Drug Administration, FDA, in 1997, are less invasive and offer some titratability in addition to reversibility, unlike the resective surgical options previously described. Since first reported in 1985, VNS has proven to be efficacious in certain patient populations for several disorders, such as treatment-resistant major depressive disorder, bipolar disorder, and epilepsy. In VNS, a pulse generator is placed under the skin in the chest and is connected to the vagus nerve by an electrical lead. Chronic intermittent VNS has been proven to be an effective option for patients suffering from medically refractory seizures who are not candidates for surgical resection. Although only a small minority of patients will be entirely seizure-free, 3 blinded randomized controlled trials have examined VNS and demonstrated significant clinical improvement compared to sham. Generally, VNS is well tolerated and safe, as device implantation is associated with a low rate of perioperative complications. Additionally, the majority of side effects are stimulation-dependent and thus reversible. For the most part, VNS is limited in its application because it can only exert its effects by altering neural activity via the vagus nerve. Procedures with brain region specificity are being investigated. Deep brain stimulation. The following summary of deep brain stimulation, DBS, will include a review of the current FDA-approved indications, as well as the expanding applications of this therapy, currently being investigated preclinically and in clinical trials. While the 1870 INCH, it is well established that administering electrical stimulation to a nucleus in the brain known to be involved in a given disease can disrupt the pathologic signals emanating to or from this brain region. A fine electrical lead is placed in a deep brain nucleus and connected to pulse generators placed in the chest in a manner similar to cardiac pacemakers. Connector wires travel from the generators in the subcutaneous space up the neck and in the subgaleal space in the head to connect the pulse generators to the electrical leads. Proper lead placement is accomplished with stereotactic guidance. A frame is rigidly fixed to the patient's head, and an MRI is obtained with the frame in place. Calculation of the coordinates of the millimeter-sized deep brain nuclei is performed in relation to the 3-dimensional space defined by the fixed frame, allowing for accurate targeting of the nucleus, figure 4233. Postoperatively, the pulse generators can be interrogated and adjusted with handheld, transcutaneous, non-invasive devices as needed for symptom control. Essential tremor. Essential tremor is the most common movement disorder in the Western world and is characterized by action tremor, 4/8 rhythmic oscillations of the hands, forearms, head, and voice. Essential tremor often starts in the third or fourth decade of life and increases in frequency and amplitude with age. Beta blockers can decrease symptoms, but patients with poor medical control and significant functional impairment significantly benefit from placement of a deep brain stimulator in the contralateral ventralis intermediate nucleus of the thalamus. In properly selected patients, DBS of this region of the thalamus appears to provide robust and durable symptom control. Parkinson's disease. Parkinson's disease is a progressive disorder characterized by rigidity, bradykinesia, and resting tremor due to loss of dopamine-secreting neurons in the substantia nigra. Dopaminergic agents such as levodopa, carbidopa, and anticholinergic agents such as amantadine and selegiline form. Figure 42 to 33. Fast-spin echocoronal magnetic resonance imaging demonstrating position of deep brain stimulator leads in the subthalamic nucleus. The basis of medical therapy. Patients with poor medical control or significant drug side effects may benefit significantly from placement of bilateral deep brain stimulators in the subthalamic nuclei. Although the globus pallidus interna has also been a widely targeted area, the subthalamic nuclei is now the most 8 disease. Deep brain stimulation provides durable symptom relief with good postoperative neuropsychologic function in properly selected patients. Recently, a large randomized controlled trial compared bilateral DBS, n equal to 121, to best medical therapy in advanced Parkinson's disease, n equal to 134. The DBS group did significantly better in both motor function and quality of life. While adverse events were 3.8 times more likely in the DBS group, 99% of these events had resolved by 6 months. There was a 0.8% risk of death due to the procedure. The FDA humanitarian device exemption has been made for DBS for dystonia, but is limited to patients greater than or equal to 7 years of age with primary dystonia, including generalized and/or segmental dystonia or cervical dystonia torticollis. Dystonia is characterized by sustained muscle contractions that cause repetitive movements and involuntary postures. Cognitive function is typically spared, and pharmacological therapy is frequently inadequate. The positive impact of DBS on Parkinson's and essential tremor has led neurologists and neurosurgeons to direct their attention to DBS for treatment of idiopathic focal and generalized dystonia. Although the pathophysiology of idiopathic dystonia is unclear, positron emission tomography studies have shown disturbed glucose metabolism in the trigeminal neuralgia, also known as tic douloureux, is characterized by repetitive, unilateral, sharp, and lancinating pains in the distribution of, typically the second but sometimes third, branch of cranial nerve V, the trigeminal nerve. The patient may describe a trigger point, an area on the face that elicits the pain when touched. A current leading etiologic hypothesis for trigeminal neuralgia is irritation and pulsatile compression of the root entry zone of the nerve by an artery in the posterior fossa, usually a loop of the superior cerebellar artery. The pain is excruciating and can be debilitating. Medical therapy, including carbamazepine and amitriptyline, may reduce the frequency of events. Options for medically refractory cases include percutaneous injection of glycerol into the path of the nerve, peripheral transection of the nerve branches, ACE-RAs, and microvascular decompression MVD. MVD involves performing a small stereotactic radiosurgery. The term stereotactic radiosurgery SRS refers to techniques that allow delivery of high-dose radiation that conforms to the 9-inine damage to adjacent neural structures. The two most common devices used for conformal SRS for intracranial lesions are the LINAC linear accelerator and the gamma knife. LINAC delivers a focused beam of X-ray radiation from a port that arcs partway around the patient's head. Linear accelerators are commonly used to provide fractionated radiation for lesions outside the CNS. They are found in most radiation oncology departments. After upgrades to the software and collimators, SRS can be performed with these existing units. The gamma knife delivers 201 focused beams of gamma radiation from cobalt sources through a specially designed colander-like helmet. Gamma knife units are used only for intracranial disease and cost up to $5 million. Thus, they are most appropriate in high patient volume centers. There is ongoing debate in the literature regarding the two technologies. Both continue to evolve, allowing more precise and complex isodose conformation to complex lesions. Most lesions can be treated equally well with either technology. Lesions abutting the medulla or the spinal cord should not be treated with SRS because these structures do not tolerate the radiation dose delivered to structures within millimeters of the target. Also, medullary or spinal cord compression can result from swelling of the lesion after the radiosurgery dose, resulting in devastating neurologic deficit. Proton beam is an evolving SRS technology that may play a specialized role in treatment of lesions where post-target exiting radiation limits photon-based therapies. For example, the physical properties of photons cause destruction upon entry and exit from tissue, which can be particularly harmful to skull base or clival lesions such as chordoma, in which the exiting pathway travels through the brain stem. Proton beam therapy. Symptomatic patients may be treated with suboccipital craniectomy to remove the posterior arch of the foramen magnum along with removal of the posterior ring. Figure 42 to 35. T1-weighted sagittal magnetic resonance imaging of a patient with a Chiari the malformation. The large arrowhead points to the cerebellar tonsil.